Today's presentation is atypical presentations of common diseases in older adults. And this presentation is brought to all of us by the Dakota Geriatrics. It's a HRSA-funded geriatric workforce enhancement program. And I just wanted to mention, we have a website that you go to, just Google Dakota Geriatrics, and they have different educational opportunities there. You can now get level 1 through level 4 certification in geriatrics through the online curriculum. We call them Gero Champs, and you get a digital badge. So you get a little bit of something for your effort there. And the feedback's been pretty decent on uptake and usability. Today's goals are to report how symptoms are different in older adults than younger populations, middle-aged folks. We want to recognize common illnesses that present differently in old relative to younger adults. So usually we understand disease as a typical collection of signs and symptoms. As an example, normal pressure hydrocephalus could often be thought of as an individual that presents with what we call wild, wet, and wobbly, which is a vernacular way, if you will, of saying that they may have agitation, they may have urinary incontinence, and they may have gait instability. So just as a mnemonic, we always say wild, wet, and wobbly. There's also pericarditis, and that typically is classified as having sharp chest pain. It occurs in 95% of the patients. Sometimes it's relieved with sitting or leaning forward. So a lot of times you'll see people bent over. It also presents with tachycardia. And so if somebody has, again, a racing heart, you have to think about pericarditis. And, if you're a primary care provider or emergency room physician, you'll want them to lean forward, and you're going to listen for a friction rub. And actually, if for those that are not familiar with a stethoscope sounds of pericardial friction rub, if you take your hair and just rub it back and forth, that's a friction rub. That's what we hear on in these instances. So what do we consider atypical presentation of a disease? And so basically it's when somebody presents with a disease that's missing some of these traditional features that we commonly describe in the medical literature. And they're very common with younger patients. And it turns out that, anywhere from a quarter to half of the disease presentations in older adults aren't what we expect. And so this is part of the reason that we give these presentations, is because we want to heighten everybody's understanding and knowledge of how these diseases present differently. And it may come as a surprise to some people that somebody that's lying in bed and says, I want to be left alone, may actually be a presentation of a disease, such as hypoactive delirium. Excuse me. Atypical presentations have certain groups of patients that are at risk. These are the same people, by the way, that are at risk for delirium. So increasing age, particularly if you're over the age of 85. If you have multiple medical conditions, we call it multimorbidity or medical complexity. If you're one of these individuals that's taking 6 or more medications, you've got polypharmacy. Dementias, all types of dementia. And then residing in a long-term care facility, whether that be a nursing home, assisted living, senior housing, and or if you have some sort of functional dependency, so those so-called activities of daily living. So there's 3 features that we need to consider. Firstly, an atypical presentation usually involves vagueness. Somebody says, oh, I kind of feel tired, sore, I'm ache all over. Of course, hurting all over could be associated with influenza, which apparently hit the UND sports program here this past weekend. And some really took some people out, surprisingly. The second thing is the alter presentation of illness. So you may see chest problems presenting as abdominal discomfort, or so in other words, the abdominal pain or discomfort is a presentation that is occurring of a disease process that's up in the chest. A good example is that somebody comes in with right shoulder pain, and if you're not prepared as a geriatric savvy individual, you may not recognize the fact that that's not necessarily a shoulder arthritis, but it may be gallbladder disease. And then the other problem is that there's an underreporting of symptoms. So people say, "Oh, I'm just getting old," or it's not, it's vague. I don't know. We'll just see what happens. And so it's you get this underreporting situation. So you might ask, what are the clues that you can ascertain in identifying atypical presentations? Well, certainly if there's a change in behavior, so if somebody becomes less active, as I mentioned, they may just want to take to bed. If they get more agitated, those could be changes in behavior. If they are delusional, if they are saying stuff that doesn't make sense. Change in function. So they may all of a sudden become incontinent, of either bowel or urine, or they just, don't want to bathe, right? So there's a change in their routine. And then also in cognition, right? So that's the aspects of delirium and confusion, forgetfulness that might be somewhat insidious. You may not notice that they're forgetting stuff, and you eventually catch up with that. And you start thinking maybe they have dementia, but it may be something reversible, like a thyroid condition. Excuse me. So the consequences of not identifying these atypical presentations is that generally things languish a little bit longer in the older adult, and so they sometimes are not so reversible. You may entirely miss the diagnosis and they get through the disease process, thank gosh, but maybe not. And then again, early treatment is important. So sometimes there's some interesting aspects of treatment. So for instance, pneumonia. If you have pneumococcal pneumonia in the older adult, you usually think early treatment is better. And it is, as a general consideration. But once you hit 90 years old, there's evidence that no matter when you start the antibiotics, if the person is going to succumb to the pneumonia, they're going to do so regardless of the antibiotic therapy. So that's a little bit different, in terms of old medical care. So from the patient's perspective, atypical manifestations may not be so apparent because they just don't know, right? They may say, "Oh, I've got indigestion," and that's their myocardial infarction. Social factors, they don't want to bother other people, so they say, just leave me alone. There may be some dependency or lack of caregiver support, and so they just, ignore the symptoms. More social determinants of health, such as lack of transportation, may be an issue. Also, there's a great fear of hospitalization, particularly thinking that not only will they be hospitalized, but they're going to send me to a nursing home. So that last point of risk of losing independence is always quite an important issue. So you might ask why older people present differently. Well, firstly, there might be a blunting response to illness. It's true, they don't make antibodies as quickly as younger people, and so the whole inflammatory response gets a slow start. Sort of like now that we're in kind of this Arctic temperatures here, it's sort of like the same concept. It's just slow to get started. There may be loss of physiologic reserve or changes. For example, they may not become, may not breathe rapidly because the oxygen sensors in the carotids and in the lungs are suppressed as you get older. And so that respiratory rate that should go with pneumonia, it should go up to 20 to 24 breaths per minute, may not happen until it's like way into the disease process. So these are 5 areas that commonly have atypical presentations. Not surprisingly, COVID and other infections don't present the same way in older adults as they do in younger. And we'll talk a little bit about that. I already gave an example of cardiovascular disease presentations where indigestion is, presents as a myocardial infarction. So when we talk about infections, there are some, we're just going to compare here typical versus atypical presentation. So the typical, of course, is you got a fever, you get chills, you might get night sweats. The atypical is no fever, or maybe just a little, as they say in Spanish, poquito, a little rise in temperature. Or you may have altered mental status, and that altered mental status may be agitation, confusion, or it may be, one of those, just leave me alone, I'm taken to bed. And then also dehydration is often a presentation that we'll see. That's why we do orthostatic blood pressure checks so frequently in the older adult. So specific infections, such as urinary tracts, we have the typical dysuria, frequency, urgency, above the pubic bone pain, and plus or minus bloody urine. In the atypical circumstances, the older adult may have urinary incontinence, and it just gets worse. Again, they may become apathetic or confused. There may be increased nocturia, this general feeling of malaise, lack of well-being, and believe it or not, when they fall, that may be an indicator of a urinary tract infection. So for those that do diagnose urinary tract infection, you have to have a positive urine culture with 10 to the 5th colony forming units per milliliter. If you have more than 2 uropathogens or bacteria, it's probably a contaminated specimen or just a colonization. You have to have what's called pyuria, so that's diagnosed by a urine analysis that shows more than 10 white blood cells per microliter. And you might or might not have white blood cell casts, and usually that indicates a pyelonephritis or kidney infection. Oh, I just wanted to mention, this has not so much to do with atypical manifestation, but if you're taking cranberry juice to prevent UTIs, good luck. There have been 3 very large studies that have identified cranberry juice does not make any difference in prevention or in the treatment. If anything, it helps with hydration. And boy, oh boy, was the Wisconsin Cranberry Society pissed off at the researchers who discovered that. So, oh wells. In terms of infection, let's talk about pneumonia. Typical presentation, again, is fever, cough, shortness of breath, and chest pain, usually with deep breathing. The atypical presentation is, again, no fever. It may show up as abdominal pain, and very commonly an older adult may come into the emergency room with, just general malaise and not feeling well and saying they have abdominal pain. They're dehydrated, and so the emergency room physician gets an x-ray, and it's like normal x-ray, but yet later when they hydrate them, the x-ray turns, changes and shows the pneumonia, and I'll show you an example of that. So here it is on the left. You've got this normal chest x-ray, and then once they get hydrated, you'll see what appears on the right side there. With the left lower lobe infiltrate, which I don't know if you can see my arrow circling around, but basically that schmutz and whiteness in the lower left lobe is that's the pneumonia. All right. Sorry, I just have to get my cursor going here. All righty. So I had already mentioned that tachypnea, or that rapid breathing rate, will be reduced with age and is not as sensitive to changes in oxygen. I've seen patients come in with, hypoxia. They've had a pulse ox of 89 to 90, and they're just talking away normally. They're not short of breath or anything. For most people, younger people, they would be having vocal shortness of breath at that rate. And so the important thing is that, particularly for people that have CO2 retention, carbon dioxide retention, such as in COPD, they may not have that rapid respiratory rate. So that's an issue. So you can't rely upon respiratory rate as a single indicator of pneumonia. And then again, the dehydration. So you always have to check people. You check for under their armpits for moisture. You can pinch their forehead to see if it tense. I can't tent me because I'm a little hydrated, but you get the idea. And as we talk about pneumonia and COVID-19, you see the typical, presentations. Runny nose. I had a lady come into clinic just the other day, older adult, and that's all she had was a runny nose. And I said, I think we better get a COVID test. And sure enough, it was positive. So, the whole picture of COVID and how it's presenting is totally different now that we've been vaccinated or we've been exposed multiple times to COVID. I'm still trying to count the number of COVID infections patients have, because some of them, wear it as a medal of honor. Oh, I've had it 3-4 times, and I'm going like, okay, that's good. Let's just see how your dementia does later in a couple of years from now. And that's a whole different conversation about COVID exposure and dementia, epidemiology. But anyways, COVID is the atypical presentation may just be simply they're not hungry, not eating. And again, the abdominal discomfort. They may have conjunctivitis or red eye. And like all other infections, they may present with falls or syncope or passing out. There's a famous infectious disease doctor at University of California, San Francisco, that posted his post-fall after he had COVID. He fell in the bathroom. He was going to the toilet, and he got up and passed out and just wrecked his head. And he says, just a reminder to everybody that even the best of us can, forget, the elements of COVID. All right, so with these echo programs, we like to have case presentations. Here we have a 91 female who resides in a nursing home with moderate dementia, falls, diabetes. She has neuropathy, high blood pressure, and arthritis. She's lying in bed at dinner time. She's arousable, but wants to be left alone. She states that she's not hungry because she has a stomach ache and is tired. So what additional evaluations should the nurse do? And maybe, we can put into the chat just to get a little engagement here. I'll take a peek. And what would you do? What's your next step? And if anybody wants to unmute themselves, if you're brave enough, please feel free. All right, I'm not seeing a whole lot of response here. I guess we're gonna. Here we go. Yeah, thanks, Brenda. I was gonna say good gravy. We've got 2024, and everybody's kicking their feet up here. We need to do some active learning. So yeah, we're talking about blood work, CBC, certainly a COVID test, and other respiratory. Yeah, exactly. So you get somebody that takes the bed, has stomach issues. We have to start thinking of upper respiratory tract issues that are happening. Any number of things, so we need to ask some more questions, basically. Is that indigestion associated with a potential heart attack? And so getting an EKG may be another consideration. So our differential diagnosis, unfortunately, broadens. And and so Diane says any bleeding symptoms. Yeah, for sure. You want to check and see if they have maybe a bleeding ulcer, gastritis, maybe they're the stomach pain. So the point being is that we need to address both abdominal issues and chest issues. Excuse me. All right. So when you have hypoactive delirium, some of the issues with, in this case, maybe hypoactive delirium. You get You want to get the vital signs, including orthostasis, of course, getting temperature, pulse ox, and blood sugar test. You should also apply the confusion assessment method, so the so-called CAM for delirium. And then, as Brenda and Diane had suggested, that we get a urine analysis, get a COVID, flu, RSV test, which are now fortunately all packaged into a PCR test, and then also a chemistry test, because sometimes metabolism is messed up. So we want to move towards atypical presentation of heart disease. And so on the left, we have a 68-year-old male who's a smoker with hyperlipidemia. You can see by the upper picture there that he has central chest pain. There's radiation into the left arm. It's a crushing elephant sitting on me type sensation, with or without diaphoresis. And older adults don't always sweat the same way that younger people do. So that leads to the atypical presentation, particularly if somebody's diabetic. You know, they, again, may be just not feeling well. They may be a little short of breath, and they may have epigastric pain. So that relates back to our nursing home patient. Could be the same thing. She had diabetes, and, you know, perhaps, you know, the presentation of pain is quite different in the diabetic. Looking at other issues for atypical presentation, how about the so-called acute abdomen? So in a typical way, we get severe pain. The bowel sounds may be diminished, which, by the way, the bowel sounds may be diminished in older adults who are taking opioids. So that can't always be a reliable sign. Typically, they'll have a tender, firm abdomen. They may have emesis or vomiting, as well as fever. In the atypical situation, again, it just gets into that general you know, loss of appetite, don't feel like eating or eating less. They may or may not have any abdominal discomfort, which is really the catcher, you know, because somebody comes in with change in appetite and they're not complaining of abdominal pain. And that is more the norm in older adults than in younger people. And then also they may present primarily as constipation. And if they haven't gone to the bathroom in 3 or 4 days, that's called obstipation. And that can be a medical emergency. And again, they'll have hypoactive bowel sounds, but again, that's not always necessarily something new, particularly if they're taking pain medications. Depression can present differently in the older adult. So, you know, commonly we see depression as a low mood, sadness, hopelessness. There may or may not be suicidal thoughts. I often warn people and our doctors in training that if you're dealing with a veteran, that to be very cautious, because a lot of times they won't express suicidal ideation, but they still may have a plan. And so you have to be a little bit more circumspect and ask different kinds of questions to tease out the possibility that they're entertaining suicidal thoughts. Also, in typical depression, you know, the thinking slows down. They may be slower in their speech. They'll talk about sleep disruption, can't get the sleep, or have poor sleep. And they've just lost interest in a lot of things. And that's called, the medical term is anhedonia. I don't think I use that word, but once every 10 years, anhedonia. But in any event, the atypical presentation of depression is more of what we call somatization. Everything aches, you know. So if somebody comes in with total body aches, you still got to work it up, and you know what the etiology of that may be, ranging from fibromyalgia to autoimmune disease to, you know, viral infections and a variety of other things. But somatization is a very common manifestation of depression in older adults, and it may actually not only be this kind of withdrawal, but it may be associated with outbursts and agitation. So a lot of times we call that agitated depression. Loss of appetite again. So loss of appetite with depression, loss of appetite with infection. You're starting to see the pattern now. There's very non-specific representation. So it's a change in status that makes you think that there might be something else going on. So let's do another case report here. We have an 87-year-old male who comes for his annual wellness visit. Lost his spouse 6 months ago. He lives alone now with adult children who live, one second. in other cities. And they see him periodically during the holidays. He's functionally independent. However, he's lost 5 pounds and is worried that he might have cancer. He thinks it might be prostate cancer in particular because he has problems urinating and his back hurts him. So he's a pretty sophisticated patient here, giving some interpretation of his symptoms. So here again, what additional information would we like to know? So if you don't mind putting it in the chat, what else you would like to know about this particular case? Yeah, perfect. Melissa, you want to know when his last bowel movement was, because if somebody's obstructed with their bowels, that can cause urinary incontinence and frequency. Excellent. Well, you get a geriatric 5-star for that one. Yeah, you want to check for bereavement. So we want to consider some other issues that might be leading to his somatization. Great. Yeah, we want to check kidney function and nutrition. Yeah, so I think everybody's honing in on exactly what we want to learn about this patient a little bit further. So certainly we'd want to do a depression screen. So we usually start off with a PHQ-2, and if that's positive, then we would use a PHQ-9 to kind of score the level of depression. So he scored a 12, which is kind of mild to moderate. And you might want to use the alone scale for loneliness. And in this case, it was positive. So this is a tool, a clinical tool that just recently got published. And so that's why I'm bringing it up as an opportunity to screen for loneliness. His weight loss is 3 pounds less than last year, so it may not be quite as significant as he's attributing it to. And also, we look back at the record, and his back pain has been chronic, so that's not new either, which is an important clue, because if somebody with new onset of back pain, that needs to be investigated a little bit more rigorously than somebody that's had an exacerbation of chronic back pain. Oh, and then also, as we did our medication, remember we still apply the 4 M's, right? So we're doing a medication review, and guess what? He stopped taking his finasteride. So yeah, he's going to be peeing a lot more because, his prostate medicine's not working anymore. So let's move to endocrine issues related to atypical manifestation. So in hyperthyroidism, you'll typically get tachycardia. You may see some tremulousness and anxiety. So, people kind of sitting on the edge of their seat. In the atypical presentation, the older adult may actually be lethargic. They may not be anxious and, all kind of jittery. They may have a depressed mood. They may be confused, and they may exhibit weight loss. So those are the differences. So a lot of times we call this apathetic hyperthyroidism in the older adult. So let's move to another case report. We have a 67-year-old female with hypertension, seasonal asthma, and presents with 1-week symptom of dyspnea on exertion. She could not tolerate climbing 1 flight of stairs or walking 3 blocks. On review of symptoms, she reported swelling of her legs. Lying down, she was breathless, and she had to wake up in the middle of the night short of breath. So that's paroxysmal nocturnal dyspnea. She also noted a 20-pound weight loss over the past 3 months. Blood pressure is fairly normal. Her heart rate is elevated at 103 beats per minute, normal respiratory rate, good oxygenation. Physical exam shows a palpable thyroid gland and pitting edema of her legs. And so the question is, what do you think's going on here? So do you think it's hypothyroidism, hyper, new onset of heart failure? Is it an asthma exacerbation or a pulmonary embolus? So this is a differential diagnosis that might come up with these presentations. And I'll just let you make your own choice here. So as we move in to the answer, we want to do some workup, and some of the tests that you might consider here would be things like an echocardiogram, because she might have some heart condition. Might want to do pulmonary function if that hadn't been done already. If you're looking at the potential of pulmonary embolism, you're going to get a D-dimer, as well as a ventilation scan, that so-called VQ scan on the right side there. I typically like to get lower extremity Dopplers. And of course, we want to get the thyroid panel. Typically, you only need to get the TSH. The beta natriuretic peptide is also to evaluate for heart failure. So it turns out that this individual had a very high thyroid, so that and a very low TSH. So that's classic for hyperthyroidism. So you can see here in the middle here where it says thyroid stimulating hormone, the normal range is 0.3 to 5.0. And this individual had very, very low levels. Sometimes they'll say they're even undetectable. And so that suppressed TSH is a result of the elevated thyroid T3 and T4. You can see her T3 level was twice the normal range, and that with treatment, they all went down, which is good. But again, the presentation was atypical. So in terms of apathetic hyperthyroidism, the TSH, the thyroid stimulating hormone, just by itself can provide the diagnosis. Most of these cases are from autoimmune, and they're not related to cancer. People always say, "Oh, I've got an overactive thyroid," and then you worry about thyroid. Very unusual. And so it's reassuring for the patient to know this. In this particular case, the reason why this individual was having shortness of breath is because she had pulmonary hypertension. And that doesn't always come with hyperthyroidism, but it is very responsive to therapy. And so I presented this case because it adds to the medical complexity. And so when we talk about the geriatric 4Ms, we also talk about geriatric 5Ms, and the fifth M is medical complexity. So I think this is a good case in point that showed that not only did the individual have thyroid problems, but as a consequence of the hyperthyroidism, she had pulmonary problems superimposed upon her asthma. So, you can start seeing how medically complex this gets. And for the unprepared diagnostician, they're going to miss it, right? And so that's why we emphasize geriatrics training and covering issues like this. That this is what a geriatrician's paid to do, is figure this kind of stuff out. So I'd like to summarize by saying atypical manifestations of disease in late life are or is common. If you see a change in cognitive or physical status, start thinking about an atypical presentation of a disease, whether that be infection, myocardial problems, abdominal, or otherwise. And then finally, that the brain is really the major sensor of these changes. And so it's important that when you have confusion, lethargy, do the confusion assessment method, and make sure to rule out delirium, and then also try to rule out metabolic and other issues that are associated with that change in cognitive status.